Good morning, good afternoon, good evening, everybody, wherever you are in the world. Welcome to this first IAGES International webinar on complications in rectal cancer surgery. As we know that worldwide, rectal cancer and colonic cancers are increasing in number, and more surgical options, especially minimal invasive techniques, are becoming more popular. So we thought today that on behalf of IAGES, we will discuss this topic of complications in cancer surgery. And today we have a dream panel. I couldn't have asked for better panel from all corners of the world. The people who are in the middle of the game, who know the game, who understand the game, who have been teaching, training, discussing, publishing about rectal cancer, all are here. I'm going to introduce my panelists to you. First of all, Professor John Marks, who is not new to all of us, but it's customary for me to introduce him. He's the Chief of Colorectal Surgery at Mainline Health System. He's a very decorated personality. He's also on the Executive Committee of National Accreditation Program from Rectal Cancer. He's a Program Director, Minimal Invasive Colorectal Surgical and Rectal Cancer Fellowship at Lankenau Medical Center, Philadelphia. He was very famously involved in color trial, and he has numerous publications to his name. He has written various chapters in different books. If I continue to read his biodata, I think I will need an hour. So with this, I welcome Professor John Marks to this panel discussion. Welcome, Dr. Marks. Next, I have Dr. Hua Zheng, who is again a very decorated personality from Shanghai. He is a chief of the Department of Gastrointestinal Surgery at Ruijin Hospital, affiliated Jiaotong University School of Medicine. He is also the director of Shanghai Minimal Invasive Surgery Center. He is presently president of Chinese Society of Lepro-Endoscopic Surgery. He is on the governing board of ELSA. He is also a board member of IFSIS. He serves as a chief of editor of Journal of Laparoscopic Surgery. He is very keenly interested in research, publication. He has around 400 papers to his credit. I have a very close friend of mine, Dr. Tan. And as you know, Dr. Tan is from London. He's a professor of surgery at the School of Medicine, Anglia Ruskin University, which is one of the newest medical schools in England. And he has been practicing laparoscopic colorectal surgery for last 20 years. He's also on the Council of Coloproctology of Great Britain and Ireland, and on the board of the International Society of Laparoscopic Colorectal Surgery. He has a passion for education, global surgical collaboration. He's also at present the treasurer of the Association of Laparoscopic Surgeons of Great Britain and Ireland. And his focus at present is on outcomes on digital surgery in post-pandemic world. Then I have Dr. Ramesh Adnari, who is from my own country. Dr. Ramesh Adnari is a very senior surgeon, and the first people who started laparoscopic surgery in this part of the world is the chief of the GI surgery in Meenakshi Mission Hospital in Madurai. It's a teaching hospital, and he has very keen interest in research and publication. Dr. Nawar Alkamezi, who is assistant professor, Department of Surgery at the University Hospital, London Health Sciences in Ontario, Canada. He's a surgeon of repute in that part of the world. He's very deeply involved in research, training, and teaching. Last but not the least is Professor Shahadat Sheikh Hussain, who is from my neighboring country, Bangladesh. He's a very eminent colorectal surgeon in his country, and he has done his training from Edinburgh and Glasgow. He's a laparoscopic colorectal surgeon. He is a professor in Sheikh Mujib Medical University, Dhaka, Bangladesh. I welcome you all on behalf of IAGES. I also have a good fortune with me to welcome Dr. Raman Goyal. Dr. Raman Goyal is a very eminent laparoscopic surgeon, and is mainly interested in metabolic and bariatric surgery apart from other laparoscopic surgeries. He's currently the president of Indian Association of Gastroendosurgeons. Also the chairman of scientific committee of World Laparoscopic Conference, which is going to happen in 2024 in India. With this, I welcome Dr. Raman Goyal, and I invite him to please kindly give us few words of encouragement.
Thank you, Deep. Thanks for the introduction. Friends, I'm an old hand in colorectal surgery. So I was doing laparoscopic surgery from 1992 till 2011. I was doing everything when I gave up all other surgeries, and now I do only bariatric surgeries for last 9 years. So welcome to all colleagues from all over the world. As is customary, the president gives a brief introduction about the association. So our association started very early in 1993. We are 27-year-old organization now. And this organization is basically an academic body which recertifies surgeons, which trains surgeons. And we also have a quarterly journal, PubMed Index Journal of Minimal Access Surgery for a long time. And once the COVID hit India, it was a challenge for our association. And we started with the COVID webinars, a series of webinars over 1 month, 10 webinars to educate not only surgeons, but even family physicians. And we also converted ourselves into a service organization to provide protective gear for physicians fighting war in government hospitals. As government geared up and started providing that, we have taken a back seat at the moment as far as that is concerned. And now we have, under this task force, we created a task force under which we provided these protective gear. Now, for last 1 week, we have started master classes in basic laparoscopic procedures for average general surgeons and surgeons who are starting laparoscopic surgery. And we have started these international webinars for advanced surgeons who have been doing surgeries for a long time. This is the first in the series. We are going to have our next one next Thursday, which will be on GERD, and the bariatric one will be thereafter on the next Thursday thereafter. We are also starting online fellowship programs, which is done routinely, which was never online. So the endoscopic bariatric program, essential laparoscopic program, and also the advanced laparoscopic programs are being started online from July. Now, our national conference, which is typically held in February, will be held next year in Coimbatore, in Tamil Nadu, and we'll be very happy to have you all join us there. We have also started regional cooperation. So we have signed agreement with the Society of Endolaparoscopic Surgery of Bangladesh, Maldives, and it's in process with other neighboring countries to happen so that we have more academic collaboration. And obviously, the World Congress of Endoscopic Surgery, which will be held first time in India, is in Kolkata in 2024, and we'll be definitely seeing you all of you there. So that's the end of my welcome. I welcome Dr. Sheikh, Dr. Ramesh Hardhanari, Dr. Zeng, Professor Marx, Ten, and Dr. Nawar Al-Khamesi, and my moderators, Dr. Deep Goyal and Dr. Anil Haroor. So Deep, over to you. Thank you very much for inviting me in this August presence.
Thank you so much. Thank you, Dr. Raman. Thank you. And I would like, before I start, I would like to introduce my co-moderator, co-host, Dr. Anil Haroor. Dr. Anil Haroor is a surgical oncologist, and he heads the Department of Surgical Oncology at one of the famous hospitals in Mumbai called Fortis Hospital. And he's a very, very accomplished minimal invasive GI oncosurgeon. So with this, I would like to start, and I would like to start by asking first question to Professor Marx. What are the common complications you witness during rectal cancer surgery, Professor Marx?
We try to avoid them, but of course the challenges of rectal cancer surgery we're all aware of. You know, the major complications of surgery being bleeding, having adequate length for the bowel to reconstruct things, and to avoid ureteral injury and to avoid ischemia in the bowel itself. I think that the key to doing that has to do with proper anatomical surgery. But I think they're kind of the major issues in the immediate process. And then more longitudinally, postoperatively, has to do with pelvic abscesses or infections, particularly after neoadjuvant radiation therapy, which predisposes the patient for that, and the possibility of an stricture of your your neorectal conduit. That I think would encompass most of the problems one can encounter.
Thank you very much. So
Dr. Deep, can I add one more to this list?
Please.
I think that one more which we, especially if initially the tumor was bulky, is tumor rupture during handling at surgery. And then that sort of messes up, especially if there is a loaded fecal content. Then you have a mess in the pelvis with all the feces coming.
So these are some of the common complications, as Professor Marks has also listed them: surgical site infection, anastomotic leak, hemorrhage, LAR syndrome, urogenital complications, ureteric and bladder injuries. So I would move down for the next question to Dr. Shahadat Hussain. What are the red flags when you see a patient in your OPD? When do you can always say that this patient is going to be high risk? What are you see in a patient in your practice when the patient walks into your OPD?
Oh, thank you, Deep. Actually, the patient's most important red flags are in terms of the carcinoma rectum or colon carcinoma. We probably will focus on the carcinoma rectum if we get patient with the persistent rectal bleeding without having anal, the asymptomatic rectal bleeding persists more than 4 to 6 weeks. And moreover, the patient got the alteration of bowel habit, and it is for more than 4 to 6 weeks. And when we examine the patient, the palpable rectal mass and recent onset anemia. And I like to add another important thing, what I feel in my private practice in Bangladesh, that is the mucus discharge. Some young patient are coming with the mucus discharge, sometimes mixed with blood.
Dr. Sheikh, what I'm trying to ask is, what patients, when you see what are the red flags which raise in your suspicion in your mind that this patient is a high risk patient for complications?
Okay, so these are the things when I get this from this patient, I think this patient might have the carcinoma, suffering from the carcinoma rectum, and so that I will give the importance to this patient and early diagnosis, and I'll go for the management protocol. And moreover, with this symptom, if the patient come with me with the elderly patient and with multiple comorbidity, and this sort of patient, I will give more importance, and probably during the surgery, this patient might have some complication.
Right. So, as you rightly said, people who are elderly, who are immunocompromised, patients who have already had neoadjuvant treatment, diabetic, low albumin, low-lying lesions, obesity, ulcerative colitis, CRF. These are some of the red flags which cautions us that these patients may land up with more incidence of complications. So we need to be
yes, of course. We should be very careful when we go for the total assessment of the patient preoperatively before going for the surgical management or NSCRT, whatever we plan in MDT. We have to total evaluate this patient preoperatively.
Absolutely.
COVID times, and in COVID times, a lot of times people are very hesitant in examining a patient. I just wanted to know, Dr. Ramesh Ardhanari, how important is a PR, and do you think that just doing an MRI will be enough and will assure you that you don't land up in a problem on the operating table? Will you be happy with just doing an MR?
No, I like to do a rectal examination preoperatively, especially for rectal cancer, because very often the patient is often seen by a medical gastroenterologist, and they just take a biopsy, and then they don't write the exact lengths from the anal verge. That is, which is what we are interested in, knowing where is the lower limit of the tumor. Is it a circumferential tumor, especially in males? Is there an anterior involvement? And then can we reach the upper part of the tumor? How big is it approximately? So I think that these things cannot come with only an MRI. These you need a rectal examination. That gives you a very accurate concept. It also gives you a concept of the patient's ischial tuberosities. So you know whether the space between that will be sufficient for you to do a low anal anastomosis. Some patients have a very narrow gap, and you know that even the stapler head 31 may be difficult to put through that gap. Then you will have to alter your management. So my workup includes a clinical examination, and usually in rectal cancers, I like to take a good chunks of biopsy and multiple biopsies, and so I do a examination and anesthesia preoperatively along with an MRI. I stage the disease, then I refer whom I have to refer for neoadjuvant chemotherapy. Some patients with very advanced lesions, now we go for what we call as total neoadjuvant therapy, give all the chemotherapy and radiation up front, and then take the patient up for surgery. And of course, the MR of the pelvis is must, because it correlates very well with the gross specimen. So we routinely do an MR. I still find a lot of patients coming with CTs, but I insist that they should have an MR up front and then an MR after the neoadjuvant before surgery. And we try to correlate and see, has the tumor shrunk, has it grown, has it remained steady, so that we have an idea of how the outcomes will be.
So an important takeaway from this is that we just don't rely on just the scopy finding. A lot of times the endoscopist measures the distance from the anal cleft. So it is somebody sitting holding the scope. So you don't get a distance from the anal verge or the dentate line, which is what we are interested in. So very well put, Dr. Ardhanari. And there is nothing, we have to follow that adage of Love and Bailey, that if you don't put your finger in the rectum, you will definitely put your foot into it. That is one important message. There is nothing replacing the PR, especially in a low-lying rectal growth. Otherwise, you can get into problems in the operating room.
Thank you. So we all know that preoperative bowel preparation, there's a lot of debate. Sometimes we say it has to be done. Sometimes we say it doesn't have to be done. And there are various ways. I'd like to ask Dr. Tan whether in their practice they do bowel preparation. If yes, what kind of bowel preparation? And what is the impact on SSI and anastomotic leak?
So in our hospital, we are now using mechanical bowel preparation and selective gut decontamination with neomycin and metronidazole. This is a fairly new practice. When I first started in Colchester about 19 years ago, we didn't give mechanical bowel prep, and we didn't give any antibiotics. We just gave a low residue diet leading up to surgery. We were doing laparoscopic surgery for about 80% of our cases, and we had a phosphate enema as the cleaning on the morning of surgery. Many of our colleagues felt uncomfortable for low anterior resections, having a column of stool in the rectum, in the left colon, and there were some concerns. And so we changed our practice without much evidence. And as you know, what enhanced recovery has done is it's pushed people to try and avoid bowel prep, etc. So we went without bowel prep. Now we have come to having bowel prep, and of course, looking at the data from NSQIP and the Cochrane reviews that came out in, the meta-analysis that came out in 2015, there was evidence that mechanical bowel prep with oral antibiotics reduced surgical site infection. And in fact, many of the studies, including the Dutch SELECT study, has confirmed the reduction in SSIs. Anastomotic leak, as you all know, is a much more complicated, multifaceted issue. So there are two things. Philosophically, one has to understand whether or change one's thinking to think, is an anastomotic leak a vascular pathology or is it an infectious disease pathology? And if you follow John L. Verdi from America, he's done some beautiful YouTube videos about his thoughts on activation of strep fecalis, the collagenases that then continue to break down anastomoses. So I think there's a theory about oral antibiotics, but it hasn't shown through consistently. And you can see this in the guidelines, how they vary from the States to Canada to India to Australia to the United Kingdom. So the short answer to your question is, I use mechanical bowel preparation. I use oral antibiotics beforehand. And there seems to be good evidence that SSIs are reduced. Anastomotic leak, we need much more data, but I suspect there is a trend towards a reduction.
Right. Ramesh, what are your views in your practice from India?
I have always prepared the rectal cancers. Provided that there has been no subclinical or clinical obstruction. So I always prepare the rectal cancers right from the beginning. The colonic cancer is a different thing, and we did not prepare, but for the last now 10 years or so, after the NSQIP papers and studies, we have been preparing. There is some evidence in rectal cancer from the Grecor trial from France that the preparation of the rectum is good, that if you prepare, you have less abscesses and less septic complications. So rectal cancer, I prepare both mechanically and with oral
chemically as well.
Neomycin and metronidazole, exactly like Dan said. We use the same.
What about Professor Marks in your practice, in your part of the world?
Yeah, I would say that all along we've used mechanical bowel prep along with oral and intravenous antibiotics. It seems to me inherently obvious that decreasing the fecal load in the abdominal cavity, the operative field, is going to decrease your complications thereafter. I mean, there's a reason we wash our hands before we operate. And to think that you're going to expose the operative field to that amount of fecal matter doesn't make sense to me. And then just from a personal standpoint, honestly, when all this data came out, I said, I just think it's grotesque to be operating in all that stool. And I'm going to be the last person in the world to change to a no bowel prep. You're going to have to show me very good data to do it. So I was happy to see things confirmed, which I think makes a common sense to it. And in terms of what Tan was saying, I'd like to add that, clearly anastomotic leaks and infections are more multifactorial that have to do with tension, blood supply. And I think if you have a problem, then the bowel flora is going to be an issue. And if you don't have a problem and it heals nicely, it won't be. So
there is some evidence as well, as Stan was saying, that this is a Klinger's paper which very clearly states that combined preparation lowers the risk of SSI and organ space infection, wound ascents, and also some evidence to say that anastomotic leak, symptomatic anastomotic leak and pelvic sepsis is going to be much less.
Deep, I would like to add one more point.
Please.
There are some people who argue that if you're going to put an ileostomy, there is no need to prepare. I actually go the other way. Yeah. I tell people that if you're going to do an ileostomy, it is because it's a high risk for your anastomosis. Therefore, you must prepare, because if you don't, then the motion between the ileostomy and the rectum that if there is any minor leak or major leak, it's going to cause much more problems. So you must prepare if you're going to do an ileostomy.
I would agree with that and add the point that if you don't prepare, you're going to have a large fecal column cephalad proximal to your anastomosis that at best is going to sit there and become problematic until you close the stoma, and at worst will
months together,
give you the leak that you have.
So I think
in the OR room, the last thing a surgeon wants to see is a fecal matter in the abdomen. So from all points, I think we all agree that for rectal cancer and probably from left-sided cancer, bowel needs to be prepared. Well, individual practice may vary whether it's only mechanical or combined chemical, but at the moment, I think the literature is tilted towards preparing with both types.
I think just one important footnote to this is we are just starting to understand about the microbiome. And I would encourage researchers to biobank their material and also to try and understand what it does to the microbiota when you mechanically and orally decontaminate. Do we change radiochemosensitivity afterwards? What are the effects on the immune system? We are just starting to understand this very vital role. So we may stop the immediate problem, but are there other issues that we are not really aware of? So understanding the microbiome is we're just at the foothills, I think.
So I agree with you, Tan, there. There is a lot of work on the microbiome, and especially with use of neoadjuvant chemoradiation, these things are getting more important because radiation is supposed to change the microbiome again completely. And that's something which leads us to the anastomotic leak that we are going to focus on here. Professor Zeng, what do you think is the incidence? What is the incidence of anastomotic leak that you would ascribe this procedure to? And do you really see a similar kind of incidence in your practice? Professor Zeng?
Yes.
So we were just talking about the incidence of anastomotic leak in literature. And do you think that this is reflected all across the globe, all across centers? What do you think really makes, and do you see it in your center as well? The incidence of
the most reported in literature, the incidence of anastomotic leakages from the state or Europe, from 10 to 20%, especially for lower rectal cancer. But from our experience, from my department, we have about 1,700 cases a year, 60% rectal, less than 5%. Because recently, with improve of laparoscopy technique, we have nearly 95% procedure in the laparoscopy. And also for low rectal cancer, low rectal resection, we do the ileostomy, dividing stoma systematically. So clinically, the leakage, anastomotic leakage is less than 5%.
Right. So I think the literature does show a very similar kind of incidence that it's a wide variation. This was a multi-center analysis coming from Korea, and it showed a range of 3 to 21% within the country. So I think it is something that is varies from institution to institution. Lot of factors, as we will discuss in our panel as we go ahead, does lead to influencing anastomotic leak. Interestingly, the International Study Group of Rectal Cancer graded these leaks into A, B, and C, where A is a subclinical leak which you just diagnose when you do a workup of the patient for an ileostomy closure. Grade B is something that can be treated conservatively and radiologically, and grade C is something that requires surgery. Professor Mark, would just like your comments on the grade B and grade C management. How do you differentiate between the two radiologically? Would you consider radiological putting a pigtail or a stenting perhaps? Professor Mark?
Yeah. You know, I think that in terms of stents, we're not really very big fans of the stents. You know, pigtail catheters can be very helpful in this regard. And, you know, also, of course, it has to do with whether or not the patient's proximally diverted.
So I wanted to know the fine line. How do you decide between, you know, this patient, I'm going to open this patient, intervene, give a wash, do a stoma, or, you know, I'm just going to put in a pigtail there and going to watch him with antibiotics? What would be a red flag that you would raise?
I think that's a great question, and it's a multifactorial, of course. Generally, it has to do with what the status of the patient is clinically. If the patient is clinically sick, they're the people who are going to go to the operating room and I think that's the safest, recognizing that there's a risk incurred by doing that. Sometimes you will end up taking down an anastomosis that didn't really need to do that by doing the dissection. If the patient has a lot of comorbidities, I'd be more aggressive with someone who's older and sick, who has bad comorbidities, because they won't tolerate a failed percutaneous drainage. And it also has to do with the magnitude of the problem. You know, if someone has a localized issue, it's obviously different than if they have multi-loculated cavities, or things that you'd be more likely to want to take out, go to the operating room and wash out. And, you know, I think that it's well to remember that the morbidity of negative laparoscopy or relatively negative laparoscopy is quite low, and the morbidity and mortality of going in too late is much higher. So there is no easy answer to that. But I think that it has to do with most localized controlled abscesses where the patient is not septic. I will drain these percutaneously with a catheter. And if the patient is showing signs of significant systemic sepsis, or they seem to have multifactorial things, or if I'm concerned that there's perhaps significant ischemia of the bowel, all those factors will lead me to take them back to the operating room.
Yeah, that's great. I mean,
can I add something, Anil?
Yeah, sir.
I think apart from everything that Dr. Mark said, which is absolutely acceptable and the right way to go about it, I think the senior surgeon, the one who has got a lot of experience, does a careful rectal examination, especially for the low anastomosis. And you try to feel how much has given way. And you find that more than a quarter of the circle has given way. Sometimes even a half circle has given way. These patients need to go to the theater. That's a big leak. It won't stop on its own. But if you don't find any give in the anastomosis, and you find that there is no real gap, then it would likely to be your small anastomosis, and even a pigtail might work. I think that is also an important thing, but that will also correlate with the sickness of the patient, which is the standard that most of us would use to decide whether to operate or not.
Yeah, interesting. But the key operating word would be probably a senior experienced surgeon, because if somebody is going to put a finger into the rectum in a anastomosis which is already fragile, he might probably convert a small leak into.
That is why I made that first statement.
Yeah. Professor Navar, I think it is best not to go to that place and try and prevent it right from the beginning. So, what are the principles you would advise the audience watching here to achieve a very safe anastomosis? You are not audible, Professor.
Dr. Navar.
You're muted still.
Can you hear me now?
Yeah.
So
now we can hear you.
Okay, so the best treatment is prevention, as you correctly said, and the principles for safe anastomosis is starting with basically a tension-free anastomosis. And when you do rectal surgery, taking the splenic flexure sometime become a mandatory process, especially if you're doing a middle to lower rectum, so an ultra-low anastomosis or a coloanal anastomosis. You need to make sure that your bowel sits nicely in the pelvis. The anastomosis is tension-free. In addition to that, you have to have a well-vascularized tissue. And now with the introduction of ICG, this is an extra step to make sure that you have viable and healthy tissue on both ends, your rectal end and your colonic end. So these are the steps to take. In addition to that, when you are putting your purse string around the anvil, you need to choose your right anvil. Make sure that you don't chew more than what you can buy. So the tissue need to be clean. The anvil need to sit nicely. The purse string technique is quite important to make sure that your anvil is snug to introduce it down to the pelvis. And I always make sure and advise people to have an experienced person firing the gun from the anal side. It's quite a job. It needs to have a steady pressure and steady hands to actually get a complete ring. Once that's done, I always make sure that there is a flexible sigmoidoscope in the room.
So I would like to ask, yeah.
Yeah, go ahead.
No, that's fine. Please can continue.
A flexible sigmoidoscope to visualize the anastomosis and also do an air leak test. If you don't have a flexible sigmoidoscope, a careful rigid sigmoidoscope is valid. And now with the ICG, what we tend to do is to do it before and also after. And you could actually look in the inside and see that you have a complete anastomosis. It's all viable. It's all vascularized. Make sure that your donuts are complete also. So the three major principles, good blood supply, tension-free, and good technique will give you a safe anastomosis.
May I ask you a question? What is your preference? Is it an end-to-end anastomosis or a side-to-end anastomosis?
Well, that's a great question, and
we will come to that, Ramesh.
We will come to that.
Let's not jump again. Yeah.
Okay.
Let's stick to the script.
Oh, I didn't know it was coming. That's why I asked. Okay.
That's fine. So another to Professor Marks. Professor Marks, what do you think? By diverting the stoma, do we reduce the risk of anastomotic leak? We reduce the symptoms of the leak?
Yeah, well, that's a fantastic question, and one we'll probably never know for certain. I think that probably what we do is a little bit of both. Clearly, you decrease the symptomatic leaks and the real life-threatening leaks that one might encounter with low rectal cancer, low rectal anastomoses, particularly after neoadjuvant therapy. Most likely, there's a middle ground of patients who would have had a small problem had they not been diverted, that without the fecal stream, it allows things to heal without being exacerbated. And but I think that's probably a small percentage. So I think that, and particularly in the low rectal anastomoses, we have to look at the consequences long-term functionally of having an infection in the pelvis and what that'll do in terms of making a fibrotic neorectum and increasing incidence of large type symptoms.
And in your practice, what are the indications of a stoma, Professor Marks? Which patients you do not make a stoma? Let me put it this way.
So for patients who've had all anastomoses in the distal 3 centimeters of the rectum get diverted, and those who've had neoadjuvant therapy routinely get diverted. Someone with an anastomosis higher in the rectum after neoadjuvant therapy will selectively not divert, but generally that's the indications.
What about Dr. Hussain? In your practice, what are your indications of doing stomas?
I absolutely agree with Marks. And in my practice, in every center there are some debate about the stoma and no stoma, but in my practice, I actually do any anastomosis below the peritoneal reflection, I go for the diverting stoma. Not only that, in some cases, after getting the post-NSCRT patient, even in the above the peritoneal reflection, I consider the comorbidity like, the immunocompromised patient. And the patient who is right now fit for the elective surgery, and if I consider this patient may not be fit for the emergency surgery if leak is there and laparotomy is required. So particularly those patients, I go for the elective stoma, and I agree with Marx. I do believe this stoma reduces the anastomotic leak and the consequence of the anastomotic leak and the reoperation, and it reduces the pelvic sepsis. And most important issue, what I feel in my practice, at the colonial anastomosis, if the leak is there and if this patient needed laparotomy and the diversion, probably this patient might have the permanent stoma for the lifelong. That is another important issue I consider. And if I say my own,
just add one thing to what I had said. The flip side of all this is that I feel that when I follow my patients postoperatively in the first 3 months, I probably have more complications related to the diverting loop ileostomy than almost anything else. And so it's a very challenging problem. And I've invested a lot of energy and desire into avoiding them. And I think we are going to see, there are several companies that are working on local barrier techniques to try to avoid that. So hopefully this will be something that we can work together to change moving forward.
If I can just,
please, I was coming to you. Your views.
Yeah, so I agree with what's been said, and I would just say, make a couple of points. One is what John has just said. Stomas come with their own set of problems, and we have deaths associated with stoma reversal, C. diff infections. So a stoma is not the panacea. I think we all need to uphold the principles of good surgery. The second thing is that there was a couple of studies done by the Colorectal Society of Australia and New Zealand, and then the Association of Coloproctology. The decision to place a stoma, an ileostomy, was made basically on heuristics. So it was something that people did because it felt right. And what I would urge people watching this is to look at the risk factors for anastomotic leakage. So these are preoperative factors that are patient-related and disease-related. And the Association of Coloproctology group that I was part of has published a booklet or guidance on prevention, diagnosis, and management of anastomotic leak. And what we have stated there is that it's ideal, if you're going to be taking part in this sort of surgery, to make the decisions based on risk before you go in. There's some flexibility, but you should make those decisions about stomas preoperatively, because you can pretty much stratify the patients into those that are higher and lower risk, because just a blanket rule of stomas will lead to other problems. And of course, we only find problems if we measure them.
Thank you, Tan, for very useful words. So this is some of the literature which very clearly indicates that people who have had stoma had less anastomotic leaks, and people who did not have a stoma had more anastomotic leaks, and morbidity, mortality is correlating with it. There are a lot of randomized trials being done, meta-analysis, which are again saying the same thing. And even the Cochrane review say that, they have a protective effect if you make a stoma. So these are the indications of creating stoma. And when we say eventful surgery, what we mean by this is if the surgery has been prolonged, or there is more blood loss, more than 100 ml, or if you have used 3 or more staplers to dissect the rectum, to cut the distal end of the rectum.
So another thing that that leads to a lot of anxiety among surgeons, especially those who have just started the laparoscopic procedures, is where do I ligate the IMA? A lot of confusion regarding oncological principles of high ligation versus low ligation, though we now know that theoretically these have been settled. Still, I would like to ask Professor Zeng and Dr. Ramesh, first Professor Zeng, about their views on high versus low ligation of the inferior mesenteric pedicle. Professor Zeng.
Yeah, actually, since 2 years, it's a very hot topic in China, high or low, because it's old questions. Because high ligations, there's no much bigger issue of vascularization, because actually we have some technique with ICG. But with improvement of laparoscopic technique, we can easily dissection lymph node in the root of artery, IMA. So we try to, some studies try to preserve left colic artery and can have proximal column vascularizations, high vascularizations, and we want to decrease the leakage rate. But statistically, there's no difference from two groups. But technically, preserve, that means preserve left colic artery. It's technique is easy now. So actually in China, both two techniques. Ongoing study, yes, still many center ongoing study. So actually half, I think.
So, Professor, if you had to mobilize the splenic flexure, do you think that doing a high ligation would be mandatory, or you would still go ahead with?
Because in China, Asian patients, we have a long sigmoid. So we very few cases we need mobilization of splenic pressure. Normally we don't need it. So if we initially, if we preserve left colic artery, we have some problem of tension. But if we dissect the number 253, and you have this caudal approach, you can fully mobilize the left column. I think from our practice, there's no major problem of tension. Maybe Chinese surgeons, Chinese patients maybe have long splenic sigmoid, and also practice. Now there's no major problem of the tension if we preserve colic artery.
Yeah, Dr. Ramesh, your views?
So initially, I used to always take it at its origin, and I used to be selective about the patients. So now the thing is that we know from the studies that looking at the lymph nodes at the origin is not of therapeutic importance, it is of prognostic importance. If you have a node there, if it is positive, then you know that this patient has a bad outcome. It's virtually equal to a metastatic disease. So what I do is that I clear the nodal tissue around the inferior mesenteric artery. And in most patients, I'm not saying all, but in most patients, I tend to take the IMA after the left colic has taken off. That way, improving the blood supply to the stump. If it hampers the length, then I will divide it. If it doesn't, I will just keep it and go ahead with the anastomosis. There is no literature to say that randomized trial to say that it increases the blood supply, but I just keep it. Anyway, nowadays, we would always check the blood supply with the ICG test. So I think the discussion is a little irrelevant at the moment.
Professor Marks had a comment.
Yeah, I was going to say that, I think there's highly variable on the anatomy of the patient. In the West, in the U.S., I mean, I routinely say we routinely take down the splenic flexure and we routinely do a high ligation of the IMA. As has been stated, from an oncologic standpoint, these N3 nodes, if they're positive, it's metastatic disease. It's not really that. It has more to do with length. If you're in the upper rectum, not so much of a big deal. Going down distally, it is a big deal. You can't do a coloanal anastomosis, at least on a heavy set patient in Philadelphia, without taking their IMA. And more importantly, more length is gained by taking the IMV inferior to the pancreas than probably taking the IMA high. But all three of those things are, in my opinion, central to having a tension-free anastomosis, which is probably the most important aspect of avoiding an anastomotic leak. We don't really see, I honestly can't remember taking the IMA high and having and losing the descending colon, losing the area that's supplied by the left colic. So anyhow, that's what our routine practice is. And I recognize that in the East, with longer sigmoid colons and different body habituses, there are obviously different solutions needed.
I think, and the other thing is probably now with ICG coming in a big way, maybe we'll be more, more at ease in ligating the high IMA at a higher level if need be. There are several papers, as we can see here, which talk about this topic. Essentially, there has been no significant difference. An interesting observation made is, as we are all discussing, is that colonic ischemia is probably higher when you ligate, when you do a high ligation of the IMA. And splenic flexion mobilization is performed less frequently when you do a low ligation. So these are obvious anatomic observations. I don't think it would take, it is a foregone conclusion according to me.
I think that from a practical standpoint, oftentimes what leads to poor blood supply to the colonic conduit of the left colon is not the high ligation of the IMA, but the surgeon buggering the mesentery and the marginal vessels going to what they're doing. And so, again, I think it's difficult to tease that out in a study, but for experienced surgeons like you have on the call and in the audience, I think they recognize what I'm talking about there.
A more interesting thing, that is that goes along with high and low ligation is that whether we have a change in the genitourinary and the sexual function when we do a high and low ligation. This paper does not seem to say so. That it feels that a low ligation has a better genitourinary function. And I would
Anil, that is logical because the nervi are going around the base of the IMA trunk and then diverging from there. So when you go low down, the chance that you will have a damage to the nerve trunks by either cautery or by one of your energy devices is higher than if you stay away. But then when you clear the lymph nodes and you don't divide it, even then you have the same choice. So you have to ask from the trial, did they attempt to clear the lymph nodes or did they just do a high ligation?
So it was something which was quite focused on symptoms. So I do not think that was something which they addressed it.
So this is something that is very difficult. So you have so many variables that it is a little difficult. Again, you'll have to separate the neoadjuvant away from the non-neoadjuvant because we know that neoadjuvant groups have a higher incidence of nerve damage and urinary and sexual symptoms. So you will have to separate the two again.
Yes.
If I may make a comment.
Yeah.
I think to John's point, this is all about quality of surgery.
Absolutely. I would agree completely. Yes.
And it's also about situational awareness. So we know that we have nerve plexi around the base of the IMA trunk. We know where the nerve plexi are around the vesicles and in the pelvis. The problem is when you are in a stressful operative scenario, sometimes we will end up causing inadvertent damage, as it has been outlined here, not just to the nerve trunks, but also to the blood supply if you're trying to take the splenic flexure down. So I think that's a point of caution for the audience. You know, there is a potential to cause damage either to nerves or the blood supply, but you have to carry out the principles of surgery to get the best oncological outcome. So going back to the point about splenic flexure mobilization, I mobilize the splenic flexure routinely now. And so I have changed my practice. I do it routinely because I always mobilize the splenic flexure with the patient on their side. It takes about 20, 25 minutes. I have adequate length. And what is really good is I can get into anyone's abdomen. So I can laparoscope anyone because you can get the pneumoperitoneum. But you've done quite a hard part of the operation already. And if you get a 100, 120 kilo man, you know, if you've got good length and you've done the splenic flexure nicely, then you can focus on the technical challenge of that pelvis. So I think one has to think about where one wants to get to, as well as these specific points, nodal points along the operation.
Let's come to the next question to 10. How does one assess the vascularity of the bowel and make sure that we have a well vascularized anastomosis? What is your trick?
Okay, so this comes back to whether you believe it's vascularity or an infectious disease that causes an anastomotic leak, and also to my point about high quality surgery. So there is no doubt that vascularity has an impact on your anastomosis, so you need to maintain it. So you know, you need to use your eyes. So you need to look at the colon, you need to look at the blood supply. And of course, the old-fashioned way is to look for pulsatile flow in the marginal artery. What has really revolutionized my practice is ICG. And, you know, to be on such a stellar faculty is great because everyone has talked about these issues. So the PILAR trials and you know, some of the other literature has shown that ICG can alter your level of anastomosis in about 5% of cases, and there is evidence that, or a correlation of a reduction of anastomotic leak. Now, I find that very difficult on an intellectual basis, but what we do know is that ICG is an adjunct along with what I call the triple test, the underwater air leak test and the flexible sigmoidoscopy, to looking at the quality of that last bit of the operation that we do, the bit that we do when we're tired. So in summary, I like to do ICG assessment, visual assessment, and that's my assessment of vascularity. I would also like to say I do a lot of, I do like to do a bit of cognitive rehearsal before my surgeries, and we need to stratify the patient. So preoperatively, if you have patient factors such as diabetes, age, smokers, you know you're going to be in with a vascular system that's not so good. If you have an intraoperative event, as you call them, then you know that there's a bit of a risk. So those patients need particular care and attention.
Yeah, I agree with you, Chen. And this was one of the interesting papers that it was a multi-center phase 2 trial where there were 504 patients and ICG was used, was 2.6% leaks. And where ICG was not used, there was 5.8% leak. And in the cases where ICG was used, it helped in changing the site of the division in around 5.8% of patients, and these patients did not have leak. So yes, we are getting now some literature which is saying that use of ICG is helpful whenever you can use one. Yeah. And in our personal experience, in our practice also, what I have seen, sometimes it is difficult in borderline cases in laparoscopy to really make out whether this is well vascularized or not. So there are three categories. One, you definitely know that this is ischemic, and one, you definitely know that this is well vascularized. And there's a third category where you're not sure. And I think that is where ICG comes in very handy. And if you divide this much bowel, you will be struggling to get it down to the pelvic rim. And I think that is where ICG has a scope.
So I'd like to challenge some of that, because, is this just the Hawthorne effect? Just because we're measuring it, we're getting a bit of bias in what we do. What I would suggest is that the use of ICG just puts some steps in our assessment of anastomosis, and we look at the health of the anastomosis, and I'd like to use that word, the anastomotic health, a little bit more closely. Whereas in the past, I think as surgeons, we were so technically focused on the oncological resectional part of the operation. So we're finally focusing on stapling, blood supply in a bit more detail, and actually how we fashion the anastomosis. So I think ICG is just part of that story.
Yeah, probably. I think, as you rightly said, this is just.
I have a question to Dan.
Sorry,
Yes,
Dr. Marks is about to say something very wise, I'm sure.
I don't know about that, but I would just echo some of the things that were said. Can always speak very eloquently, but I think it's probably not fair to say that we didn't always spend a lot of time looking at anastomoses. And I think that, as was very well stated, is it's obvious which anastomoses are fine when the blood vessels squirting you in the eye, and it's obvious when it's black, which is not healthy. And I think the challenge, and ICG is a fantastic adjuvant to trying to make these differentiations. The challenge comes depending on the experience and comfort level of the operating surgeon. The senior professor is going to need this less than someone who's just getting started in their training, in the same way that ureteral stents have never been shown to help avoid ureteral injuries. But for the relatively novice surgeon, they're going to be more helpful than for the very experienced surgeon. And so I'm an advocate of using ICG on a routine basis. If it helps 2-5 patients a year in your practice, that's a big deal. And the reason why I recommend using it routinely as opposed to selectively is the worst time to use ICG is if you're not used to looking at it, and then you're going to use it for the first time that month on the one patient that you're really concerned about. So I think it makes sense to use routinely. It doesn't cost much financially. It doesn't cost much time. You can't use it in patients who have allergies to IV dye, but for the most part, it's helpful. And for those people that you're on the fence, it may push you one way or the other. So
I completely agree, John. I think what I was trying to do is just make sure that we don't use it like anti-locking brakes in a car. It still means you have to drive the car properly. So ICG is a very useful adjunct, but it is part of really judicious and careful surgery.
I think it doesn't bail you out.
Very important point by Dr. Marks, that if you do not use it regularly, it's difficult to train your eye. When you really require it in difficult situations and your eye and brain is not trained to recognize, it's a problem. So it's better to use it routinely, since it is cheap and it is easy to use. So
I have a question to Dan. Can I ask?
Dr. Sheikh, we are just running out of time. Can we take the questions at the end, please? Yeah.
Okay. No problem.
Sorry.
I think we have discussed about splenic flexure. Can we move on to the next question? Because I think we already
I think we will
discussed it.
do that. It's just,
Yeah.
These are some of the papers. They're saying that after you mobilize the splenic flexure, you really gain significant length in the. So what are the common bleeding sites, Dr. Nawar? And from where in your practice you get maximum bleeding, maximum times, and what do you do about it?
Well, I would divide them into bleeding outside the pelvis and bleeding inside the pelvis. Outside the pelvis, the major two issues here, you have a pedicle, which is basically that could bleed into like the IMA or the IMV, or you have a splenic bleed. And most of the splenic bleed happens due to a tag on the spleen rather than an injury to spleen. And these are easy to control intraoperatively. You could, depends on the way you take your vessels, whether with an energy device or whether you staple or you put a clip. And if you have a splenic bleed, a bit of pressure with a hemostatic agent is usually good and safe to avoid that. When we come to the pelvis, that's the problem. That's where the fun starts. And the presacral venous plexus is an extremely hostile bleed. And we've all been there, and we've seen that pooling of the blood when you cannot see or you could control what you're doing. There, one of the most important things is just to stay calm. That's extremely important. Have a chain of thoughts that you could try to basically start with a method and then add the other and then add the other. So start with a bit of simple pressure, see how that goes. There are fantastic hemostatic agents you could use like Flow Seal, Seal, whatever you could use, whether you are doing an open or a laparoscopic procedure. Both of these agents could be applied laparoscopically. And keep the pressure, take your time, and give yourself some time. The major problem with the presacral venous plexus bleed, when you put and apply pressure, people get very nervous, or they are eager to actually finish the procedure. And time here and pressure are your friends. So keep the pressure, do something else. If you have another step in the procedure, do it. If don't, just take a break, take 5-10 minutes break, let things settle down. It might not stop the bleed, but it will make it easy for you to control. The last thing you want to do to a presacral bleed is to put a blind stitch or use an energy device, which make probably a simpler bleed even worse. And if that happens and you think that you're not controlling it, pack it, bail out, give it a day, come the next day, you're fresh, the patient is good, and take it out. There are other things we could do. I sometimes use a peritoneal patch, take a piece of the peritoneum or the omentum and stick it onto the presacral area, and then use a high energy device like your cautery on a high things and try to melt that. We used to do that at St. Mark's quite a lot. And that usually is good in helping you stopping the presacral bleed. And again, if that doesn't happen, then just pack, give yourself time, come back and do it again. Now, after you perform the anastomosis, sometimes you have a bleeding anastomosis. And if you could see it while you are in the operating room, that's fantastic. With your flexible sigmoidoscope, you could clip it, you could buzz it, you could put a stitch in it. That's brilliant. If it happens when you are outside the operating room, then if it's mild and the patient is stable, I don't do much. Keep observing the patient. And if there is a problem, then you could always scope and deal with it. Now, we have major bleeds. Sometimes that happens when you are closer to a major vessels like your common iliacs or the internal iliac arteries. And these are intraoperative issues that we could control. And again, if you know that the patient has need a wider margin or a pelvic wall dissection, and you think that you will need a vascular colleagues in the room, or if you are trained in vascular surgery, then get the sets ready, get all your things ready with you, and try to control those bleeders before they happen. And if they happen, then you at least have somebody with you to help you in those circumstances. Very rare to see those major vessel injuries in the experienced hand, but the presacral venous plexus was one of the major bleeders. And again, time is your friend with those, and have a strategy. Start with the simplest things to control and then progress as you go. And there is no harm or shame in just packing, getting out and coming back again, and you will see that the bleeding had stopped and you could finish your anastomosis after a few hours and you're good to go.
Thank you very much for such a response, sir. So just to summarize what you have said, that first of all, do not panic, pack it, go away, have a cup of coffee, maybe call in your colleague to look at it from a fresh perspective, come back again, have a look, make sure your suction is working. If it is visible, if it is on the surface, you think you can take a stitch, take it. If you want to call for help for a vascular surgeon, call it. You can pack it, come back at a later date. That is also acceptable. But the point is, do not panic and have control of things. Make sure your suction is working. Make sure you have a colleague which is there to help you. Fantastic.
Deep, two things.
Yeah. 1 second, Ramesh. Let me show you this video. This is a case done by Anil Haru. And you see, we saw a bleed of the inferior mesenteric artery pedicle, and how cleverly, this is a robotic APR, how cleverly he has controlled it by holding it and by applying a clip right at the right point. Yes, please, Ramesh, you were wanting to make a point.
Two things. One is that when you have this presacral bleeding, you pack it and you go out to have a coffee. You leave your senior assistant with an instrument which will press down on this and keep pressure for the 10 minutes that you're out. Because the gauze piece packing alone may not cause sufficient pressure to stop the bleeding. But you keep a hand to give some pressure that will often stop the venous bleeding. So that is one thing. Second thing
Point well
is,
taken, yes.
The second thing is that when you have to pack the abdomen and come out for bleeding, it is better to take the decision early. So in the first half of my career, whenever I packed, it was, by the time 6-8 units of blood had been given, the patient was hypotensive, cold, acidotic, and we packed and then we went on to a ventilator. The patient would go out for ARDS, the next day we would remove the pack, there would still be diffuse bleeding. The patients didn't do well. For the last few years, the once in a year time when we have to pack and come, I usually do it early, before we have got too many transfusions, before the patient has become cold. And the advantage is that these patients all survive. So the decision to pack should be taken early before too much of transfusions and hypotension has occurred.
Yeah, that's very well said. And this video is also showing that also can be controlled by minimal invasive technique as well. This is my video. We are going into a plane and suddenly we find blood. And like a fool, I'm trying to cauterize it and it increases. So this is the internal iliac branch. And then once we grabbed it, we are packing it, making sure that our suction is working. Once you pack it and the bleeding is well controlled, your heartbeat comes back to normal. And then you can see the hole in the internal iliac vessel there. And then you take a suture with 3-0 proline. That is where the role of assistant and a good suction comes into play. If your assistant is good and he's sucking and showing you, things can be very easy. This is a video of anastomotic leak postoperatively doing a sigmoidoscopy, and you can see a bleed at the anastomotic site. And there you can either take a stitch from outside or you can apply a clip or glue or injection with your gastroenterology colleague.
Or an
this is just an
laser.
algorithm, as Professor Nawar was. Majority of anastomotic bleeds stops on their own, and less than 1% require blood transfusion and intervention. If you diagnose them intraoperatively, you can inspect the staple line, you can either apply clip or suture, or if you diagnose them post-operatively, you can still do an endoscopic management. You can do injection, over-the-scope clips, And if the bleed is torrential, you can do angioembolization, and rarely you require surgery.
So
Now we move on to genitourinary complications, and I would request Anil to ask the question.
so this is the genitourinary complications.
Anil, are you there?
Yes, I'm here. Can you hear me? Deep, can you hear me? Yeah. Hi, Deep. Can you hear me?
Yeah.
So genitourinary complications are an established this thing. So complete problems after rectal surgery. So Professor Marks, what is this? What is the incidence generally, and again in your specifically with your unit?
I mean, I would say to you that this is probably one of the findings which is most spoken about and is encountered and is probably the least well studied. It's hard to get good, accurate data in this regard, particularly if you haven't taken the data not only preoperatively, but pre-treatment from the neoadjuvant therapy, as this will all impact things. We probably run in terms of temporary urinary symptoms in the range of 8 to 10% of patients. We routinely leave the Foley catheter in for about 4 to 5 days, or if they're going to go home sooner, just until they go home, because the incidence of urinary retention post-op is relatively high. Long-term incidence is probably around the range of 3 to 5% in this area. So it is, again, difficult to know for sure, because if you ask the patients just post-operatively, if you haven't prospectively obtained the data, they're going to compare themselves to how they were when they were 22 years old, as opposed to how they were at 68 with diabetes and after the radiation before the surgery.
I would like to just make a comment that I am not able to recall the name of the very famous Norwegian colorectal surgeon. I heard him speak at the European Colorectal Congress, and he showed that as far as the sexual problems post-operatively in men is concerned, it is there was a great difference between as to who was asking the questions. And in their study, they had 3 arms. The question was asked by a young, attractive nurse. The question was asked by a male nurse, and the question was asked as an anonymous internet question. And the same group of patients had 25%, 50%, 75% sexual dysfunctions on the 3 groups. That who asked the question. So this question can sometimes be answered by a little hiding the facts by the patient, because it's a sensitive personal issue.
And, I would also add that it depends on what you're operating for and how big the tumor is. I mean, there's some tumors that you're going to have to take the nerves as they're involved in the area of the cancer, and some that aren't, whether or not you're using radiation or not. So it's a complicated question.
So then we come to how do we prevent it? So what are the common sites where a surgeon could injure the nerve?
Yeah, well, there are 3 sites. One is for the urinary function, and that usually occurs when you take the nerves at the IMA level, where the 2 hypogastric plexus will branch out as an inverted V. The other 2 sites are when you're going near the lateral ligament, where the nerva erigentis go close to the rectum. So if you go a little further away towards the lateral pelvic wall, your energy sources can damage those nerves. And the third, and probably for the sexual function, the most important area is the anterior, the dissection in the anterior fascia, because there the nerves, as you know, they go in front of the fascia. So if you are going to have an anterior based tumor, you want to go in front of the fascia because you want to make sure there's no local recurrence. Therefore, there's a high chance that the nerves could be involved. So these are the three common sites, and I think most of us take very good care of the pelvic nerves now. They are well visualized and we protect them. Most of us are taking good care of the nerves near the lateral pelvic wall and near the so-called middle rectal vessels, which actually don't exist in many patients, but where we do the dissection, we are careful. But where we can't help avoiding the injury is the anterior fascia in men, where it is very difficult. The denonvillous fascia, if you have an anterior tumor, you have to go anterior to the denonvillous fascia. And therefore, you are likely to injure the nervi irrigentas as they come in from both sides. And so that is a high site of injury. And but that is, as Dr. Mark said, you have to clear the tumor. That's the first thing. So with my patients, I always discuss in an anterior low tumor that there is likelihood that when I'm doing this, sexual problems may come, and I warn them before and take consent for that, because if they don't consent for it, I would not operate on those patients because they can be troublesome later.
So that's an important comment. I think we have to discuss this with our patients, because patients are even in India, this was not so much of an issue about 10-15 years back. Now it is. Now people do ask these questions, and we have to really discuss all these potential problems before going ahead with surgery. Dr. Tan, how does one prevent these injuries? What are your tips and tricks about preventing these nerve injuries at all these three levels that Dr. Ramesh mentioned?
So you've heard the levels where these injuries can happen. So I think this is about training and careful dissection. So what I say is situational awareness. When you're operating, taking time to be, if you know your anatomy, you take care. You have to have judicious use of energy in these areas. So what I would say to you is you've got to think about how you can cause damage. So that's thermal injury or direct trauma by cutting them. You need to know when and where. So that's the situational awareness at the base of the IMA, the nervi irrigentas, and around those seminal vesicles. So if you're aware, then you just need to take care. So again, to bring the driving analogy, if you know that there's ice ahead, you just slow down and operate much more carefully. And then when you get a clear road, nothing there, then you can proceed without problem. I think those are the most important things. And I think John Marks said something very important. Preoperatively, we do not really get an idea of what the function is. And I think having, even if you're not formally testing this, I think it's important in the era of really good informed consent to speak to your patient and actually ask them the questions that you need to ask, so that actually you've got a good idea post-operatively if you actually have caused a problem. Sometimes it's very obvious. So I think in terms of prevention, it's just comes down to take refuge in anatomy, careful dissection, and be aware in patients that may have other factors that may contribute. For example, edema post chemoradiotherapy, men with a narrow pelvis. But really the key is, I think, anatomy and careful dissection.
Deep, actually in 1993, well before we did a lot of cases laparoscopically, in the open era, we did a series of 12 patients where we actually did penile tumescence monitoring preoperatively, and then 3 months post-operatively. And we also looked at bladder function preoperatively and post-operatively with a with a cystometrogram, and then we want to see how they void. All these were male patients, and the operations were either low anterior resections or abdominoperineal resections. And we actually found that we had a they had not recovered. There was a 40% in the first 3 months, but 15% of them recovered. But another 25% had permanent nerve damage to the erection thing. And we were able to treat them with intracavernosal injections, and but they did have this complication. And in the bladder, we found that 10% of the patients had permanent, around 10% had permanent bladder problems and required self-intermittent catheterization.
So we will come to that in a minute, Ramesh. So I think Dr. Tan made a very important point that it is a surgical technique. It's a direct visualization of the nerves, knowledge of anatomy, and sometimes neuromonitoring. Though in my practice, I have never done that, but the literature suggests that one can use these devices to make sure that you do not injure. I don't know what is the experience of other analysts on this. Professor Marks, do you, during your practice, use some kind of neuromonitoring?
Yeah, they're called my eyeballs. No, yeah, no, we don't use it. I've never used any of
never used, yeah. That's what I thought, yeah. Okay. So we will move on to, so Professor Nawar, what are the common urogenital symptoms you see in your practice?
Well, the major one is the erectile dysfunction, and we all touched on that, and it's prominent. And I will echo what my colleagues have said and add to that. It's important actually to document the functional status before you operate. And from the follow-up color trial, they found about 50 to 60% of their patients have problem before even they started the treatment of some sexual dysfunction, especially erectile dysfunction. Most of our patients are above the age of 60, 65, and they have other comorbidities that affect their sexual dysfunction. So erectile problems are quite prominent, and it's very troublesome for the patients. However, from experience and what published data is if you actually talk to the patient prior to the procedures and they understand what to expect, some of them will accept that fact, and they will be well informed, and they are prepared to actually go ahead with the procedure. So it's quite important to talk to the patient and deal with it. As Dr. Mark said, this is an understudied area, and I don't think there are a lot of options we have post-operatively, unfortunately, to help those patients if the nerves already been damaged. And that's why prevention probably is one of the best treatment here. With regards to the urinary tract, retention is the major issue here. And again, before the procedures, we talk to the patients, especially male patients above the age of 65. Sometimes we start them already on a prophylactic tamsulosinus, for example, before they come to the operating room, and they continue after that to get the catheter out quickly, and then also help them with their discharge earlier and have a smoother recovery. Very, very few patients will have symptoms of, especially male patients, symptoms of prostatitis or prostatitis, and that is either due to infection caused by trouble to the urinary tract, whether it's injury or retention or prolonged catheterization, or due to the inflammation caused by the surgery of the radiation. And these can be dealt with easily. If it's infected, then you can prescribe the antibiotic and treat the cause, and if they are inflammatory, you calm them down. I know we mainly tends to focus on men, but women also have a lot of issues here. The urinary retention is another major problem in women, and sometimes incontinence, and these need to be addressed appropriately. And also the gynecological health we're talking about here. So unfortunately, I do a lot of young patients, and I talk with them about fertility issues, about the chances of injuring or damaging the tubes or the ovaries, when we do IPs, it's important to actually know where the tumor is, because you might have to take the posterior wall of the vagina, and what that affect the patients and their future sexual function. Symptoms like vaginal dryness, ulceration of the cervix, and the vulva due to radiotherapy. These are all quite important issues, and I think women tends not to talk about their problem, unfortunately, and being a male surgeon might not feel comfortable talking to you about it. But if you approach them before the start of the treatment, have this good relationship with them, and engage the family. One of the major issues here, especially with sexual dysfunctions, and particularly in women, is the stoma. When you give a patient a stoma, they feel that their body image has changed, and they don't feel they are can participate in such a thing. And it's quite important to kind of engage the partner here, whether be part of the treatment or part of the support group, and that will help ease the urogenital dysfunctions or the sexual dysfunction that happen with it. My colleagues correctly said that some of them are inevitable. You're gonna have them due to the tumor location or the severity of the disease. Thankfully, now with the introduction of minimal invasive surgery, whether it's laparoscopic or robotic, we could see those nerves better, especially with robotic surgery. We could actually trace them from their origin to where they go, and be more careful in dissecting and not damaging those nerves. Again, it's a good relationship with your patient. Discuss with them in front, and make them aware of it. I think you will have a smooth ride with them, and they will understand where you come from.
Thank you, Dr. Nawa, for such a very comprehensive answer. As we understand that this is a very, very complex problem, and it's very difficult to discuss all points in this short time. So, but very rightly, it's been said that it is very important to recognize that this is a very, very significant problem. We need to talk about it. We need to discuss with the patient and the family. We need to assess the sexual function and the urinary function preoperatively. Whatever is the protocol, whether it's a questionnaire or where some kind of investigations, and that's a baseline before surgery, and then we need to repeat it after surgery and keep talking about it. These are some of the investigations which may be required. Most of the time we would take help of our urological colleagues, but this is a urodynamic study is something which is very routinely done by urologists. And most of the times for urinary complications, CIC is done for 2 to 3 months, and most of the times patient recover. If it is a long-term problem, then again you require urological help. So since we are short of time, I'm skipping this part. And how to treat sexual dysfunction, Dr. Nawar has already said that low dose sildenafil for a couple of months till a spontaneous recovery happens. If the recovery is happening close to an year, it is unlikely it will happen, and then you require some sort of prosthesis or inflatable devices. So these are some of the options. Coming to another important point, which is what are the incidence of ureteric injury 10 in your practice and in literature? How do you encounter this?
So in terms of ureteric injury, the incidence, I looked up the paper looking at US data from 2001 to 2010. So the incidence is about 8%, looking at about 2 million procedures. So it's very, very low. So again, take refuge in anatomy. You need to have situation awareness. You need to actively look for the ureter in left-sided resections. And I would say, I would echo John Marks's point that ureteric stents may not necessarily be the way forward. It adds an additional step into the operation. What may be wise is that if you see a difficult pelvis, difficult technical procedure with a large mass, then of course using ureteric stents will help protect the ureter. but in a routine procedure, I wouldn't say that's the way forward. There has been use of ICG, squirted retrograde, used in endometriosis cases, which may help. But I think the most important thing is anatomy. It is careful dissection and, again, awareness. There are risk factors for injury, and that paper that looked at those 2 million cases seemed to suggest that a rectal cancer, increased adhesions, malnutrition, and patients with metastatic disease were slightly higher risk of having a ureteric injury. Obviously, I didn't have any data on the grade of surgeon who was operating.
Yeah. So these are some of the pictures of ureteric stent illuminating ICG. And as you very rightly said, knowledge of anatomy, mandatory identification, and using the new technology is some of the ways. This is just a video where we are showing that there is a bleeding happening at the site where the left ureter would be. So one has to be very careful while using energy sources. One needs to really identify. In this particular video, the operator almost must have caused the thermal injury, but he was fortunate to recognize it in time. So one should be very careful while using energy sources. How to treat ureteric injuries, Dr. Hussain? What would you do if you find the injury on table?
Oh, to be honest, if I have some urologist colleague in the operation theater, I usually call them. But in my personal experience, in one cases I did, it was very simple injury. I put a double stent, I just repaired, and later on I referred this patient to urologist.
Dr. Zhang, what is your practice in your institute if you have a ureteric injury identified on table?
Experience. Yeah, I've only 3 cases since 20 years, but I treat myself with stent and suture and the guidance of urologist. And
yeah. So if there's an on-table diagnosis, you can either call for help. They will do cystoscopy, stent, or repair.
Always on table. Yeah.
Yeah. If it is diagnosed delayed, then you have to do contrast study and then maybe repair and reconstruction. This is just one of the videos, my video, where we have injured the right ureter. It's a very bulky tumor. And this was just a side injury, partial injury. We recognized and put in a stent and closing it down with 3-0 Vicryl, couple of stitches, and the job is done. And there's another video which is of very early surgery in my career where we have completely transected left ureter while doing a rectal prolapse surgery. Fortunately, we recognized call for help from urologists, and they put in a ureteric catheter from below, and we are taking the stitches. This is a complete transection, as you said, you can see. And after mobilizing the ureter, we are closing it with 3-0 Vicryl. And coming to the last part of our discussion is anterior resection syndrome.
Okay, so anterior resection syndrome is here to stay, basically. It's a multifactorial problem. The symptoms happen in almost every patient. About 80% of the patients will have some sort of symptoms related to anterior resection syndrome, and it's either a single or a combined symptoms, and they range from symptoms like urgency, frequency, clustering of movement, which means that the patients go to the bathroom multiple times in a very short period of time with the feeling of either incomplete emptying, or they have to go back because they feel that the stool is coming out again. Sometimes that might end up also having symptoms of incontinence and erectile bowel movements. The exact cause of it happens due to multiple factors. So the effects of it is related to the level of your anastomosis. The lower the anastomosis, the higher the chance of you having symptoms. The radiotherapy alone or in combination of chemotherapy sometimes doesn't help. Talking about straight anastomosis versus a pouch or a side-to-end anastomosis also, it's a risk factor. These are all a combination, and of course, to add to that, sometimes when we do the resection, there are also the nerve injuries and what have you. That comes to play with the symptoms. It's quite important to warn the patient that these symptoms will happen later on, especially if the patient is defunctioned and you're going to close their stoma. So these symptoms will happen when you actually reverse the stoma. So it's 6 months or a year down the line from your original surgery. Complication of the surgery itself, whether you have an anastomotic leak that created a fibrosis, whether it's a redo surgery, these are all factors in actually putting the patient at a higher risk for anterior resection syndrome. Now, how do we manage this problem? There is no magic bullet here. All what we need is a combination of multiple things. Education is very, very important. Introduction of dietary and fluid mobilizations, and it's quite important. Bulking the stool sometimes help. Keep the patient well hydrated. Try to avoid things like caffeine, heavy alcohol intake. Sometimes milk avoidance also help to help with that too. I usually give the patient a combination of metamucil and dietary changes, and that usually help. We could go to the next level. There are things have been used, like sacral nerve stimulation, for example, has been shown to improve some of the symptoms of low anterior syndrome. And if all fail, then we have to go back to a stoma, unfortunately. Very rarely to do that. Most of the patients are aware of it, and they could compensate somehow to live a normal life. I tend to speak with the patients before the surgery. It's quite important. When you have an 85-year-old gentleman or a difficult mobility, then they might be better off with having a stoma rather than actually a coloanal anastomosis. So you select your patient very well, and if it happens, try a combination of things to modify the patient's life and get them better off. Are we going to get rid of it? I don't think so.
Yeah. So, Dr. Nawar, thank you very much for, again, very comprehensive answer. As we all understand, it's a very, very complex, multifactorial problem. Obviously, we need to be aware of this. We only wish that patient has less and less symptoms, and there are a lot of risk factors, as you rightly said: preoperative neoadjuvant therapy, tumor distance, anastomotic leak, pelvic sepsis, complete TME, and also literature suggests that these symptoms are much more in patients who had a pelvic sepsis after leak, and people who had a complete TME, or people who had a neoadjuvant therapy. There are various scores available to measure them. I will not go into the detail, but yes, some kind of assessment is possible, and it's very complex to manage them. But you very beautifully elaborated that we have, most of the time, it is an empirical treatment. It usually gets better with time. If it doesn't get better in 12 months to 15 months, then it's very debilitating. And you can do pelvic floor rehabilitation by the way of biofeedbacks, electrostimulation, retrograde irrigation, sacral nerve stimulation. And if it's more of a diarrhea, you can use bulky agents. And if it's constipation, you can use dopamine. So these are some of the things which can be used. And so that's very. Coming to Dr. Zhang, does the type of reconstruction really matter in symptoms and of low anterior resection syndrome?
Now, in our experience, we do only end-to-end anastomosis. We don't have side-to-end or J-pouch. There's no major practice in China. So in China, it's only end-to-end anastomosis. So the syndrome is very common for the anterior section syndrome. So our solutions, except your presentation, multi-treatment, multi-factor, that our experience is for this syndrome, with the time, 1 or 6 months, can be improved, some of the patients. And also, we take some medication, a little bit laxative and for patients. And also, we find a phenomenon that for even for sigmoidectomy with mechanical anastomosis, they have always such syndrome. But if you use bubble suture, hand suture, this syndrome is very low. So I think it's a little bit with mechanical suture has much more this symptom.
That's an interesting observation. I mean, if you're, are you suggesting that staplers may lead to more incidence of LARs, low anterior resection syndrome? Oh,
yeah,
that's an interesting observation. I think we'll need to do a trial for that. Dr. Ramesh, you were asking about something about type of anastomosis. Do you think it makes a difference?
Our in China only end to end.
I don't think it makes any difference.
Only end to end.
So I would do usually an end to end, but once in a while, if the end doesn't reach comfortably because of the vessels, I can use a side which will, because of the way the vessels come, the side will sometimes reach better. And if the one advantage is that you don't have to take a proper purse string at the end. If you're with a straight anastomosis, your purse string must be perfect. But with the side, you don't need to take a purse string because you just punch the head through the side of the wall. So a little bit of technical ease for learners with a side anastomosis because there's no purse string to take. So, but I have no personal preference and I have not noticed any difference between the two.
Professor Marks, your comments about type of reconstruction.
And Professor Marks, one more thing I would like also to add and ask you is, have you had to ever reverse a patient? I mean, convert a very low anterior resection to a permanent colostomy because of a severe LARS?
So we have done that. I mean, so to answer your question, the data, as has been gone over, is after a year or so, all the outcomes are roughly the same. In a woman with a big pelvis, if I have a lot of length, I'll do a colonic J pouch. For a while, historically, we always did direct hands-on cholanal end-to-end, a straight cholanal. And then for several years, I started doing side-to-end anastomoses. I actually noticed an increase, which we published on in DCNR, of neorectal prolapse with the side-to-end anastomoses, and not a great deal of benefit in terms of function. And so really have gone back, I would say probably 75% of the time we do a direct end-to-end anastomosis, hand-sewn for the cholanals. And almost always for the stapled anastomoses, it's a end. And in terms of, have I ever had to convert someone? I mean, I think we have like a 1.5% rate of patients who over 5 years have said that they would be happier. And they all have a story, you know. One person rode his motorcycle all the time and wanted this for, I mean, he sounded to be doing pretty well. I mean, for the most part, it is very uncommon. I will also say, in fairness, because of our practice, we have a relatively selective bias for patients who are very motivated to avoid a colostomy. We're often, a second, third, fourth opinion to avoid an APR. So these people are probably a little bit more psychologically invested in avoiding a colostomy than others. And, I think, again, it's a highly, I can also say that while we tell people things will improve for, 12 to 24 months after their stoma is closed, I've noticed, because we've been doing this, for 25 years with the tatas, some patients, even 4 or 5 years out, have remarkable improvement of their function for reasons that aren't entirely clear to me. So I think for the surgeon, if you're going to have satisfied patients, you have to be either invested yourself in managing their function postoperatively, or have someone with expertise in that regard, because the general gastroenterologist has no idea what they're talking about with this. And it's a lot more time in your office to get them through this than if they have an abdominal peritoneal resection. But that being said, we have an over 90% high satisfaction rate from the patients with this, which again, we published in DCNR a couple of years ago.
Dr. Marks, and with this, we come to the last question. So conversion, we know how sensitive issue it is. Usually converted patients are difficult either due to the bad disease profile or surgeons' inexperience. So I'm going to ask Dan, does conversion lead to more complication? Is this thought process correct?
Are you talking of laparoscopic to open conversion?
Yes. Sorry, I should have mentioned that.
So there's been a lot written about this, and the bottom line is, I think the first starting point is conversion is not a failure. We are trying to achieve safe and good, high-quality oncological surgery with a good outcome for the patient. The patient has to have the best surgery possible. So if that means a patient, you can't do it laparoscopically, then that's the case. And a lot of that will depend on the expertise of the surgeon, of the team around there, patient factors, and of course, disease factors. So you've got to look at things that are going to be high risk of conversion. So obesity, so these are patient factors: obesity, previous abdominal surgery with adhesions. Then there are tumor factors, tumor location, the conformation of the pelvis, which you can get a very good idea from MRI. And there are the obvious surgeon factors. And having looked at all of these, you have to then have a profile of where the difficult steps in the operation will be. And I practice cognitive rehearsal. When I'm doing these operations, I walk through them, I look at the imaging so that I know where the difficult bends in the road will be. Because I think what I've observed is when you see surgeons struggle with the case, you lose situational awareness. And the first thing that goes is your awareness of time. So you can very easily spend 45 minutes dissecting and actually going nowhere. So in my institution, we have a 15-minute rule. If you're not making progress, the assistant has the permission to say to the surgeon, we've had 15 minutes. And then we try and do something else. So if you have a patient who you deem is slightly higher risk for conversion, at the preoperative briefing, we make that clear. We then go through the 15-minute rule, and the conversion is a controlled conversion. And the reason I say that is because if you look at the data, there's some data from University of California. Those patients that are converted because there is some technical or other issue there. They're the people that are at higher risk of a complication anyway. So therefore, they're a specific group that need particular care and attention. So if you convert a patient, their length of stay, their morbidity, all of these factors are higher than obviously a straight laparoscopic case or even a straight open case. So what I would urge is to say conversion is not a failure. stratify your patients and look at cognitive rehearsal so that you don't fall into a hole and lose yourself in time. And a conversion in distress is going to lead to a poor outcome. So therefore, brief the team and make sure you communicate at all times. That's what I would say.
Yeah, I think very well said. And there is obviously evidence in literature that if leak rate is higher in patients who are converted than non-converted patients, and all oncological outcomes, though in spite of thinking, believing that they may be bad, but there are no bad oncological outcomes in conversion. But as Dr. Tan very rightly said, that conversion is not a failure, provided it is done in a reasonable time. And most of the times you can predict that this patient is going to be a difficult patient and what particular step of a procedure is going to be challenging. And if you have studied the patient very well in advance, and if you have a team which is going to remind you how much time you have already spent by not progressing during the procedure, and all these factors should be taken into account. So I think with this we come to the end of our discussion. There are a lot of questions by audience. We have time to take them all.
Can I just add one thing to that discussion?
Please.
And I think Tan said things as usually very eloquently. However, there's a fundamental difference between a controlled conversion and a conversion because of complication. And so you can't group everything together because the outcomes are very, very different. I would say to the audience, the primary goal must be to do the operation as technically perfectly in your hands as can be done. You're operating for the patient and not for yourself. And so it's not important to do this laparoscopically, robotically. It's important to open. It's important to do it well. If you are making progress and it's slow, there's no reason to convert if it's slow and safe. The time to convert is before you get into trouble, not afterwards, because, and as was noted, if you're converting, by definition, it's a difficult case. There's no surprise that those patients are going to have more complex outcomes in clinical courses, but you can control things by converting early on and doing things properly for the patient. Don't get yourself into a problem by being a cowboy and trying to put a round peg into a square hole and do things in a MIS fashion just so you can say I have a low conversion rate.
These are pearls of wisdom from somebody who's practicing colorectal surgery for many years, high volume center, and involved in teaching and training. Thank you very much, Professor Marks, for these last words. And with your permission, I would take a couple of questions. I obviously can't take all of them. What are the principles of management regarding long segment narrowing post-operatively? Professor Nawar.
Well, it depends on the length. If it's a very short narrowing, balloon dilatation, frequent balloon dilatation will improve the outcome. However, if it's a length you're talking about and it's a long structuring area, then probably operative intervention is quite important. If you could do that endoluminally, that's fine. Do a structuroplasty. If you can't, then a redo anastomosis probably is your safe bet, assuming that you want to preserve continuity. If you can't, then you're going to convert that into an endstone, unfortunately.
Another question is that, do you always do a CT angio whenever you're doing rectal or left colonic surgery? Dr. Zhang,
I don't do it routinely. I've never done it routinely unless there are indications. I don't think there is a need for that. I don't know what my colleagues will support this statement or not.
Dr. Zhang, would you do a CT angio?
No, routinely, no. Intraoperatively, we can very good identifies left colonic artery and the IMA. So no, some of very few departments they do routinely, but normally it's not a routine practice.
Right. So there's another question that if there is a ultra low anterior resection and there is a leak leading to collection, patient is already diverted, patient does not have sepsis, what would you do? So we have answered this. Professor Sheikh?
Yes, it depends. Most likely, if there is no generalized peritonitis, that can be managed by conservative manner. Because if drain is there and at the same time, what Ramesh said, that is very important issue. The rectal digital examination is very important. How much gap is there? If the gap is very minimum, so that most of the patient can be managed conservatively as it is a contained leakage. And gap is more, then probably another diversion may be required. And if the peritonitis, what I already mentioned about the generalized peritonitis, so laboratory is required.
Right. Another question is that, do you routinely drain your low anterior sections? Professor Mark, what are your views? I think we'll have to ask everybody for this. This is interesting.
Yes, my views, I always drain in.
You always drain.
Yes.
Professor Zeng?
Yes, drain routinely.
Professor Marks?
It's routine.
There have been a lot of studies on this that have shown no benefit to routine drainage for pelvic surgery. So for an anastomosis, we never drain it or almost never drain it. For an abdominal perineal resection where you have a perineal wound and always a fluid collection, we will put a drain in.
Professor Nawar?
No, I don't use drain routinely in the anterior resection group at all.
Dan?
I don't use it routinely. There was a good systematic review that, done several years ago that showed this. So I follow John's advice. When you've got a raw surface there, then that's sensible to probably put a drain, but not a routine for a anterior.
Patients who receive neoadjuvant chemoradiotherapy and who have an anastomosis 5 centimeters from the anal verge, I would routinely put in a drain. They've not received NACT. Usually, I don't put in a drain.
Right. So in my practice, I tend to drain most of the times than not draining it, in spite of knowing that there is no evidence in literature. Anil, what is your practice? Anil, you have to unmute yourself. I think he's not willing. Okay, so with this we come to the end, and only fool learns from its own mistake. The wise men learn from the mistakes of the others, said by Otto. And I am learning all the time. The tombstone will be my diploma, was said by Kit. And together, all of us achieve more. With this, we come to the end, and I thank you all very much. And by Secretary of Indian Association of Gastrointestinal, Professor Iswamurthy, who is a very enthusiastic laparoscopic surgeon, as well as very accomplished endoscopist. And I would request him to propose a vote of thanks to our esteemed panelists today.
Thank you, Deep and Anil. I think it was very, very wonderful, both of you moderating this session, bringing all the stalwarts in this field across the globe on a very short notice. On behalf of IAGES and the EC members, all the 8,000 members of our IAGES academic group, along with all the surgeons witnessing across the globe, this particular webinar on the rectal cancer and its complication. I think you put the questions right across. Even for a non-specialist like me, there were a lot of useful information I could gather, bits and pieces here and there, with the Tan and Marks, everybody giving their views. It's very, very exciting. And you put the videos in the right place to see the complications. Those, not only the rectal cancer, even for otherwise any pelvic surgery, there are lots of points to take home. See, I think surgeons across the globe, I thank all our 6 faculties across, because this is our first international collaborative academic initiative. We have done COVID webinars and we have done master classes, and this is on a big day to have such a wonderful academic feast. It's really a treat, and I really thank Dr. Alkhamesi from Canada, Professor Marks from USA, and Hussein from Bangladesh, Dr. Zeng from China, and also Dr. Tan from Colchester, UK, and of course our own friend Ramesh Adnari from Madurai, and all my two colleagues, I think Anil and Deep, I think you have done sleepless night, you have done all the homework and did very well. On behalf of my president, I thank all the faculties. I invite you on behalf of IAGES to come on February 11th to 14th, if conditions are conducive to our annual Congress in Coimbatore. I think that's a place we all meet and enjoy this golden moment. And until that time, have a safe, stay home safe. And I think it's a very, very useful day. And over to you, Deep, and congratulations for you for yet another feast from you. Thank you, Anil and Deep.
Thank you very much. It's a team effort. Thank you, Professor Marks. Thank you, Ramesh, Professor Nawar, Professor Zhang, Dr. Tan, Ramesh Adnari, Dr. Sheikh, Anil. Thank you very much. I really appreciate you guys joining us. Stay safe. See you soon.
Thank you very much.
Thanks for having us.
Thank
you. Thank you very much.
Thanks for having me. Bye. Bye.
हाँ जी अनिल भाई ठीक हो गया